So I'm Ciara McGoldrick. I am a consultant plastic surgeon and reconstructive microsurgeon based in Belfast City Hospital, and I also do a lot of reconstructive surgery here in Kingsbridge Private Hospital. So we've been using T-stats in a couple of cases, and we've done some bilateral cases, and then there was one bilateral case with one immediate side, one delayed side, on a really special patient who was an one of our theatre nurses. We were all really on edge to make sure everything went really swimmingly for her. So we made sure that we had 2 T-stats available on the day. We were all briefed as to how we were going to use this. So intraoperatively then, when one flap was in place, quite often that's a technically tricky time, because your attention is then focused on the other half of the patient, and you're hoping that this other one is like ticking along. And before T-stat, that was always a bit nerve-wracking because you might be ignoring it for maybe 30 minutes at a time. While with the T-stat attached, I could just glance over my shoulder, over my nurse's shoulder, and see the numbers, reading, and know that it's all good. As we started to work on the other side, there was a dip in the arterial reading. Well, before we start the anastomosis on the other side, which is when we're really committed on the other side, we'll just have a quick look on the first side that we've done. Undid some of the tacking sutures to expose the anastomosis and have a look, and sure enough, it had managed to kink. So the vessels had kinked, which meant that while there was still a Doppler signal and there was still a good cap refill in that flap, we never would have picked that up clinically, and it was only that we could then see the direct correlation, and then as we unkinked it, you could see straight back up again, the arterial supply went back up. And so maybe some of those positioning things had altered the position of the pedicle. We were able to really quickly remediate it, tacked it back in place, get on with doing the other flap. So then patient comes off the table, goes into recovery. Patient's been in recovery about 25 minutes. And on the other side, the second side that we did, suddenly the arterial supply starts to go off. Again, we still had a Doppler signal. Again, we still had good cap refill. So clinically, this flap looked absolutely pristine normal. But it's only because 2 hours before that I had seen with my own eyes that the machine reading had correlated to a kink in this pedicle. So my patient is now awake, and this is a patient who was an old renal transplant nurse, so she knows all about anastomosis, she knows about blood flow, and she's looking at the machine, and we'd explained to her before how we'd be using it. She says, well, do you really trust this machine? I said, well, I trusted it 2 hours ago when we were doing something to the other side, so now we don't have any choice, we need to go back to theatre. Clearly, as she's coughed and the pec has contracted, it has flicked the pedicle at a 90-degree angle to where it had been sitting originally. So just beyond the anastomosis, there's a 90-degree kink in this vessel, which meant that there was still enough blood supply that we were still getting a Doppler signal, we were still getting cap refill, but T-stat had picked it up at such. So again, that was a 15-20 minute job of just repositioning, tacking some stuff down to make sure it wouldn't happen again, and then back to recovery. Went on to have a really uneventful, 2 beautiful, happy flaps, happy patient. And so that was the one case where up until that point, even the staff were really skeptical. Do we really need this other bit of kit? You know, we're quite lucky in our unit that we have a good outcome from our flaps, that we don't lose a lot of flaps, but seeing it with one of their own, everyone's perception of how this was an integral part now of the service that we deliver. There is a number, there is a change, we have to act on it. Gold standard is clinical observation, and I would say that T-stat plus clinical observation is probably best. But you use your scientific skills to be able to do your own little experiments to prove to yourself, and then you will have your learning curve will speed up.
Thank you so much for sharing.
Not at all.
This is great, and we're so glad to have you as a
Not at
customer.
all. Thank you so much.